Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. This content is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. In the second part of the antipsychotic series, we will review the first antipsychotics. The history of antipsychotics is a story of accidental discovery that fundamentally transformed how we treat mental illness, moving us away from the era of asylums and into modern neurobiology. Before the 1950s, options for severe psychosis were grim, involving heavy sedation with barbiturates or invasive procedures like insulin coma therapy and lobotomies. The breakthrough came not from a laboratory looking for a psychiatric cure, but from a French surgeon who was searching for a way to prevent surgical shock. He began using a new antihistamine called chlorpromazine and noticed it did not just sedate his patients. It induced a state of calm indifference. When a couple of psychiatrists tried the drug on a manic patient in 1952, the results were so profound that the patient was discharged within weeks, marking the birth of the first typical antipsychotic, Thorazine. As the 1950s and 60s progressed, the dopamine hypothesis took hold, leading researchers to develop even more potent dopamine 2 blockers like haloperidol. While these drugs were remarkably effective at silencing hallucinations and paranoia, they came with a Thorazine shuffle. By blocking dopamine so aggressively in the motor centers of the brain, these early medications often caused abnormal movements we have previously aired and will further discuss in future features. The first generation of antipsychotics changed the landscape of mental health care by providing a biological treatment for psychosis. These drugs are generally categorized by their chemical structures and their potency. This is the amount of medication needed to achieve a therapeutic effect. Haloperidol or Haldol and fluphenazine or Prolixin are high-potency options, meaning they require low doses but carry a significant risk of movement-related side effects. Chlorpromazine or Thorazine is a classic low-potency drug requiring much higher doses and often causing more sedation and hypotension. Other first-generation medications include perfenazine, loxapine, thiothixin, trifluoroperazine, and pymoside, each with slightly different profiles of sedation and side effects. A table included here outlines the primary FDA-approved indications and typical dosing ranges for the most common first-generation medications still in use today. The clinical applications and dosing for these medications vary based on the specific condition being treated. Haloperidol is widely approved for schizophrenia and Tourette syndrome, with typical daily doses ranging from 1 mg to 40 mg. Chlorpromazine has a much broader set of indications, used not only for schizophrenia and acute mania, but also for severe nausea, vomiting, and even intractable hiccups, with daily doses often falling between 200 mg and 800 mg. Fluphenazine is primarily used for psychotic disorders and schizophrenia maintenance, usually dosed between 2 mg and 20 mg. For patients requiring a mid-range potency, perfenazine is approved for schizophrenia and severe nausea at doses of 16 mg to 64 mg, while loxapine is used for schizophrenia at 60 mg to 100 mg and is even available as an inhaled powder for acute agitation. Pymoside remains a specialized tool primarily for Tourette syndrome, typically dosed between 1 mg and 10 mg. While this class was revolutionary, several members have already fallen out of favor or were discontinued. Thyroidazine, Melaril, or Misoridazine, for example, are rarely used today due to their significant risk of causing QTc prolongation. Molindone was discontinued by its manufacturer in many regions simply because the demand shifted so heavily toward newer medications that it was no longer profitable to produce. Primary reason many of these older drugs have been sidelined is the emergence of second generation, which offers a lower risk of permanent movement disorders like tardive dyskinesia. But despite the rise of newer options, some first-generation antipsychotics remain essential in modern practice. Haloperidol is still a gold standard in emergency settings for acute agitation because it can be given as a rapid injection and has decades of proven reliability. Perfenizine saw a resurgence after the KT study showed it was just as effective as many newer, more expensive drugs with manageable side effects. Additionally, long-acting injectable forms of haloperidol and flufenazine are still widely used for maintenance therapy, as they provide a cost-effective way to ensure consistent medication levels for patients who struggle with taking daily pills. Okay, that's a wrap for today. If you found this episode useful, share it with colleagues across disciplines. Thank you for listening, and watch for the next part of the antipsychotic series, The Second Generations. Until next time, bye!